Hello, this is Jazayeri. This is CVI2018, Denver, Colorado. With me is Ali Jazayeri. He's a cardiology fellow at University of Kansas, and he is interested in interventional cardiology. And he's here with us in CVI. Welcome, Ali.
Thank you for having me, Shadi.
So how did you hear about the meeting, and what's your impression about CVI?
Well, I heard about Cardiovascular Innovations mainly through social media, actually, and the coverage that you all had last year. I have some friends who are also fellows who were able to come and join and present cases in the case competition. And so I became more familiar with it. And in fact, being in the Midwest, we have a number of faculty that have either interacted with or trained with some of the organizers of the conference, Dr. Saraja and Dr. Berlakis. And so understanding that, I learned more about it and then decided to apply, and fortunately was able to present a case here on the faculty, so that was an excellent experience.
So you're part of the challenging cases?
That's right, yeah.
Was it peripheral or current?
No, it was actually a structural case.
Oh, really?
Yeah.
Can you tell us about it?
Yeah, absolutely. So it was an interesting complication of a structural case where it was a patient with peripheral arterial disease in whom we had right femoral access, and then for our second arterial access we used a right radial approach. Mm-hmm. And at the conclusion of the TAVR implantation with an evolute, the patient became hypotensive, and persistently so. And so in the course of trying to evaluate what was going on, whether it was an effusion or a perforation or some sort of valvular abnormality, we went backwards and kind of backtracked a bit, ultimately found that it was a perforation of the rima that had occurred while going up with a stork wire, and something that most people would never expect to happen with a stork wire. But we were able to get on top of it and manage it, and the patient did fine. We ultimately used a covered stent for kind of an unlabeled use in the rima, but it was just a kind of an interesting demonstration of how.
So the patient had the rima as a bypass, or
no,
just the rima,
just
native artery?
Native artery. Yeah, the wire we saw, on fluoroscopy, the wire went down the rima, redirected, got back into the aorta, and everything seemed to be fine. But towards the end of the case, the patient became hypotensive, and not because of the valve. Yeah, exactly. So just kind of highlighted the importance of just being vigilant and being thorough in your assessment.
Absolutely. You're doing the case tomorrow?
The case was presented actually earlier today. So we'll see.
So you're in the pool for tomorrow.
Exactly. Yeah. So waiting to hear back. Yeah. Thank you. Appreciate that.
All right. So shifting gears a little bit toward career. So there's a lot of interest, or I would say the majority of the fellows I talk to, they're interested in structural heart disease. But also there's some challenges of finding jobs after that. Is this a concern for you, or your drive for structural means that I'm going to do it regardless of my job going to take me?
I mean, I think consistently what I've always been told by mentors in various phases of medical training is that you have to follow your passion. Yeah. And especially in fields like interventional fields like interventional cardiology, structural cardiology, you're taking a lot of risk. Yes. And so I think you have to really enjoy what you do and be passionate about it. So in that vein, I would say that if that's where my career leads me, then I would pursue it without too much concern about what potential opportunities may be available for me afterwards. Yeah. But I have heard that concern, and I've heard it from people who are currently in structural training that they were having difficulty finding jobs. And so it's hard to know really if it's a systemic issue, if it's perhaps related to geographics, and or networking in some capacity.
Because the indication is going to open up now with the low risk trials going to be published or be released.
Exactly.
So then the needs will be higher, but also the stake is high for more expert operators to be at the big centers.
Absolutely.
So for the area with underserved, probably we need structural.
Yeah, definitely. And what I've seen, being in Kansas, we definitely have a lot of that because we're in Kansas City. We're a large academic center. We get referrals from all over the state and even beyond the borders of Kansas. But certainly a number of our graduates who have gone on to become attending interventional cardiologists at sites around the state have then moved on to getting proctored training and then starting their own structural programs. And so, it just illustrates to me that there are a variety of pathways to get to that end goal if it really is to be a structural cardiologist. And one may be to go for it right away because you know that's your passion, and another may be to get the training that you feel like you absolutely need with interventional, and then to see kind of what opportunities lie wherever you end up gaining employment.
Yeah. Well, that's really good points, and thanks for being in CVI, and hopefully we'll see you next year.
Absolutely, it's my pleasure.
Yeah, see this video and also other videos also on CVI website as well as the YouTube channel. Follow the hashtag CVI2018. This is Shadi Reis from Denver, Colorado. Thanks, Ali.
Thanks for having me, Shadi.